And I want to introduce another longtime friend and colleague, and many of you know that he was my assistant director at Cal HIE for a time, Scott Chrisman. Scott's going to facilitate this panel, and they are going to focus on what's been learned by two of our largest HIOs in California. Scott is with the Center for Health Statistics and Informatics at the California Department of Public Health, and he's going to introduce dear friends who are also speakers today. Thank you all for being here.
Thank you, Pam. On. Oh, thank you, Pam. I appreciate that. Good morning, everybody. And Pam, I want to take my tie off after we rock this session, so just so that we can set the stage. So anyways, it's a pleasure to be here. I appreciate taking this time to moderate a session with folks that I admire very, very much. Having participated in the state HIE program for some time, I can say with confidence that community-based health information exchange organizations, as we'll be discussing, are absolutely central to the state HIE strategy. Given the diversity and scale and size of California, absolutely critical to making progress in this space. And certainly it's hard work, as Pam mentioned. It's very important work, and it's been a pleasure working with both of these organizations under the auspices of the HIE Cooperative Agreement, and really look forward to their continued success. And with that, it's really a pleasure to introduce to my right Paul Badillo with the Orange County Partnership Regional Health Information Exchange Organization. Executive Director, Dr. Swafford, who is the Executive Director for the Inland Empire HIE, which we saw prominently promoted in the video this morning, and then Dr. Mahdi with Riverside Family Physicians, who's a participant, key participant in Inland Empire, I understand. So with that, actually, I wanted to give each member a chance to talk about their organization a bit with you, and we'll start there. And Paul, if you'd share a bit about OCPRIO.
Well, thank you very much. Welcome, everybody. I'd like to welcome everybody to the summit today. OCPRIO was founded back in 2006 by healthcare providers, both hospitals, individual physicians, and also IPAs and medical groups. And we are truly a collaborative organization. And so what happened when we got together to look to see what was really needed in, with regard to healthcare and what was missing, OCPRIO really brought to the table a lot of different types of organizations. We brought also the healthcare agency on board, the Orange County Medical Association, et cetera. And so we looked to see what was really lacking with regard to healthcare, with information flow, et cetera. And so what happened was we went and started going down the path of developing an HIE. And so since about, we've been operational for about 2 years now. We service, we have about 2.2 million lives, 1,000 physicians participating. We continue to grow. We're one of the organizations that we looked at sustainability from the very start. We looked at this in a way that we wanted to be able to provide a product that was really very affordable to the participants. Since OCPRIO is a 501c3 organization, we weren't looking to build an HIE for the benefit of OCPRIO, but for the benefit of the community. And so we continued to do that. What we've done very successfully is not only collaborate within our community, but also collaborate outside of the community that we serve. So we collaborate additionally with other HIEs in the state, working together to be able to move HIE forward.
Great, thank you, Scott. Appreciate that. Everybody hear me?
Your mic's not on.
How about now? Not now. How about now? Not now. You got it? Yes? Okay, that sounds better. How's that? Everybody hear me? Good. So basically, the Inland Empire Health Information Exchange, much like Paul described, started off very similarly to Orange County. We began collaborating, we began bringing groups together in 2009. I think Dr. Mahdi was involved in that in the very early days as well. Really talking about how to expand health information technology in the Inland Empire, which is, for those of you not familiar, San Bernardino and Riverside counties, which, just as a side note, when you combine those two counties, it's larger than the 10 smallest states in the country combined. Huge geography, very rural in some places and very urban in others, so a healthy mix. But we began collaborating, and the concept of health information exchange came out very early on in that process. And part of that was really to figure out how to bring these key groups within the Inland Empire together to build something that would improve care for the entire community. In 2010 and 2011, a product selection process was done, a detailed product selection process, mostly run by physicians. This is the interesting thing, one of the interesting things about our environment is that we're extraordinarily physician-centric. And so the physicians did, and the selection committee went through. We selected Orion Health as our HIE vendor, signed our contract in January of 2012, and launched in April of 2012. And now, almost 2 years later, we are going gangbusters. There's some differences, there's some similarities obviously between community HIEs, and then there's some differences. So what I'd like to do is talk about the differences, because I think that, I like to think that we do things a little differently in the Inland Empire, but and across our communities of service. But I'd like to talk about some of those differences. First, we believe that sustainability is a product of growth, and that to stay isolated in a single area is not necessarily going to help with sustainability. So our growth strategy is, our sustainability strategy is growth. We are a fee-based HIE, but we are a 501c3, as Paul described in his environment as well. So we're not looking to make a profit, but we are looking to be sustainable and keep our enterprise going for a long term. The other difference is that we don't restrict participation in any way, shape, or form. So any group that has a treatment relationship with a patient has the ability to work in the patient environment, has the ability to participate in our HIE. So there's no restrictions around participation in our HIE. I think the last, probably most important component as it relates to our environment is that we obviously believe that some of the emerging HIEs in the state are just as powerful, they're just as profound as any of the others, and therefore it's our goal to help them and to partner with them to really provide the services that they financially are struggling to provide. So in other words, we work with a lot of other small HIEs, or even large HIEs for that matter, across the state to help them figure out how to deploy their technology and their services. The last thing is, and I have to point this out before I turn it over to Dr. Mahdi, is we are, I have a PhD in business, right? So I always, Drucker and Covey are kind of my thing. And for those of you who've heard the term think globally but act locally is really our mantra when it comes to how we deploy our services. So even though we do have a statewide presence in many communities across the state, we also are focused on the communities that we serve and the patients in those communities that we serve. And so it's sort of an interesting dichotomy when you start thinking about the large-scale deployment of HIE, but really are focused on the community and the patient at the center of the HIE. And so with that, I'll turn it over to Dr. Mahdi.
Thank you. I'm actually humbled to be here. I wear many hats, but primarily I'm a family physician in Riverside, and we have 7 of us in the group. And back in 2009, as Rich was saying, we were meeting and we were talking about health information exchange, and we went back and forth deciding whether we should or we shouldn't. And I think we all came to one conclusion, is we can't afford not to. Health information exchange is important to a primary care physician. I think Dr. Yee has mentioned, I'm a palliative care physician, and it's important to give the right type of care at the right time in the right place. And that is a challenge. That is a real challenge in the way changes are occurring today. And so practices, groups have to transform and change, and that's not an easy option. I think when we all got together, I'm sure we all have politics in our community. Ours is heavily, a lot of politics, and when we all got together, there was a lot of discussion back and forth on who's going to control the data, how is it going to flow back and forth, and I think we all decided to go under the auspices of the 2 counties, medical societies, which is really a standalone, really has no preferences towards one or the other, and I think that was the success, is bringing everybody together and talking to start off with.
You each touched a bit on sort of the establishing of the exchange organization. The session is about keys to establishing community HIE. Maybe each of you could talk a little bit more in detail, perhaps share obstacles that had to be overcome, perhaps advice for those in the audience that are in that process of establishing community HIE. Again, Rich, Paul, I'll start with you.
One of the major obstacles was really developing trust with one another. The participants in OCPRIA, then the founding members, really were competitors in the organization. And so as they were natural competitors, what they were doing, they have a little bit of a hesitation of working together, to partnering together. And so the ability to be able to overcome that trust was paramount. And so after that was done, it really was a much smoother road. There is an argument that natural competitors cannot be collaborators. That can occur sometimes within an HIE or any organization that you're working with, but really one of the key foundations was really to be able to find common goals where everybody had, and that was really to better serve the patient. The common goals were also to reduce costs of providing that care. And so once some commonality was established, a lot of that was really the baseline of really being able to move forward and develop the relationship that was needed to move the organization up.
So I totally agree with Paul. Obviously, the trust issues are key, but I think one of our biggest obstacles is what really related to the resource constraints in the facilities that we were working with. And we have 96 current participants, and of those 96, many of them are involved in dozens of IT projects. And those of you that in the room that work for a facility, work for a hospital or a medical group or an IPA or run your own practice or an IT know that the balance between priorities in the organization as it relates to technology are just daunting. And that was really, and it continues to be, probably one of our most difficult obstacles is just getting the bandwidth from the IT folks within the facility to be able to work forward on this project. And while I believe HIE is just phenomenal and important, not everybody believes that, obviously. So when you go into a facility and talk to a CEO and they say, okay, Rich, I'm deploying a new EMR, CPOE is going in the hospital, I've got 3 people on maternity leave, and this project is simply on the back burner for now. That's the challenge. And we thought initially, and Dr. Mahdi was involved in these conversations as well, we thought initially, you pay your fees up front, you'd be more motivated to implement more quickly. Not the case. However, we are seeing progress. We are seeing, particularly with Meaningful Use Stage 2 looming on the horizon, we are seeing groups now putting more of a priority on implementation, and so we are seeing our implementations move more quickly because of that emphasis.
I think from a perspective of a family physician, the HIE is only as good as who's on it. And our biggest challenge, I think, going forward is bringing all the solo, small group practices to get on board, and that is going to be a huge, huge challenge for all of us to make this very effective. Nobody likes change. We actually went down the road of a NCQA certified medical home, level 3, and trust me, the changes that we had to implement was horrendous, and everybody fought me day and night going forward. So I just can't imagine our community physicians, how they're all going to embrace the HIE going forwards. But we have a lot of work in front of us.
Thank you, Doctor. You actually answered a question that I had about who would you have liked to have been at the table in the organizing. So it sounds like small physician groups.
Correct. Yeah, and there were a lot of, most of our community groups are physicians sitting on the board, actually all of them. And, but a lot of us represent small group to large practice. I think the solo practice is going to be the biggest challenge. Perhaps looking back, perhaps if we had the solo practice sitting at the table with us, might help things go forward.
I would add, that, and not to contradict Dr. Mahdi, but the medical societies were both present at the founding of the HIE, and so I do think that there was representation, but I agree with Dr. Mahdi. It would have been nice to have more the individual small and solos actually involved right at the beginning. The medical societies, the Hospital Association of Southern California, heavily involved with us, but again, it would have been better to have some of the small docs.
Excuse me, and when you talk about individual or independent physicians, they really are, they're really more of the entrepreneurs out there. You have a lot of solo physicians out there. They're still working, they've got their practice, maybe a spouse is assisting them, or maybe a brother-in-law is running their IT, and so that is a challenge to be able to get them on board. And so there's also the mindset with those physicians about participating. There's hesitation, but there's also a significant issue with cost. Single physician practices don't really have the resources to be able to connect to some of the HIEs, and so that's something that has to be overcome as well.
So Dr. Monti, I'd like to turn a bit to the provider experience and ask you to share a bit about how your practice has changed in light of having the health information exchange available, and what you might share with other physicians considering this.
I think looking back at what we were going through, I think the health information exchange is just the beginning of transforming the way we take care of patients in our practice. We need to start looking at how to efficiently take care of patients. We all work very hard as physicians, but I think we don't work very efficiently. And I think the health information exchange and the health technology is going to help us look at patients in a completely different way. For example, in our day-to-day, we see probably around 20,000 visits a year between all of us. And on our day-to-day, we can look at it, and a lot of those visits actually could have been avoided. We have about 1,000 diabetics in our practice. 40% are pretty well managed. In the old traditional way, we would see them on every 3 months just to follow up. I think with the information we have now, we can actually selectively look at our patient population and decide who needs a visit versus working on an episodial type care.
In addition to that, what have the conversations been like with patients regarding the use of HIE in your practice?
Actually, we went live about a month ago, right? And I thought everybody is going to sign up to it, and so I made sure that they kept a list of those who didn't, and then suddenly they came up with me with a list of about 20 patients that said they didn't want to join, and I said, that can't be. What's going on here? And I think so there's a lot of education needs to go in to our staff in explaining to our patients what goes on, because obviously we have contact with our patients, but the majority of our contacts of our patients are with our team members in our practice. And once you explain to them what's happening, they all change their mind and they come in. So we're on opt-out. And so every time a patient comes in, we explain to them and have them sign a consent to join, to stay in. If they want to come out, they will have to sign out. And I would say 90% or 95% have all stayed in.
I want to turn again and talk a little bit about, I think, something that's fairly unique in California that's emerged as a model, and that is the HIE service provider model. And really what we've seen is with organizations represented here, essentially what were community-based HIOs providing services to other communities outside their immediate medical trading area, outside their catchment. And we've seen this really memorialized in the rural HIE incentive program administered by the California Health Equality Program with, again, designated HIE service providers, both of which Acprio and Inland Empire represent. So, really what I wanted to ask is, each of you, Rich, how do you see that impacting community-based HIEs going forward, this model that's emerged in California, and your thoughts on that? I know you've been very, very active in the space.
It's interesting how nicely the Rural HIE Incentive Program dovetailed into our current strategy. So we have a hybrid strategy, public-private hybrid strategy. We provide community HIE services to the communities that we serve. And we also provide private HIE services to enterprises who don't necessarily want to go out and spend the extra dollars to buy their own HIE. We extend the HIE into those enterprises and allow them to connect their participating or their group facilities together and do HIE internally, very similar to a Kaiser or something like that. So that combination of private-public lended itself very nicely to the HIE service provider model, because essentially what it turned into was, instead of providing private HIE to a single enterprise, we're providing private HIE to a single community, or a group of communities, or a group of counties that have come together, collaborated, created their own HIE governance, their own HIE structure, and then we come in and provide the services. Again, very similar to what we do in the private setting. So that dovetailed, as I said, very nicely into our current strategy. I will tell you that a lot of the groups that we just recently signed that are in that category, the Rural HIE Incentive Program category, probably would not have been able to launch had it not been for some of that seed money, that startup money that the HIE Incentive Grant provided. And not that they wouldn't eventually, but they wouldn't have as quickly as they have. And so I'm very excited about the opportunities to really move HIE forward in the state, not just in our traditional, where we started, but the entire state. I have facilities in 7 states now, including California. I don't claim to own any of those states, but I have facilities, I have groups, I have providers. So I'm very excited about what the Rural HIE Incentive Grant provided for us, and that is the ability to really extend HIE services in an affordable way to the white spaces in the state.
And the era of funding really provided the stimulus that was needed really to get HIE moving forward. If you look at our 2 organizations where we were 2 years ago, with the help of the funding that was available, we were able to really grow phenomenally. And that's really what the Rural HIE Incentive Program was geared to do, was really to take those organizations that were almost ready, the counties that were almost ready to move in to become an HIE, and really to help them incentivize to get them over the hump. OCPRIO has been part of that as well, and what we've seen working with some of the counties is that they were really in the same place where we were 2 years ago. They needed to organize, they needed to get together. They had some questions, some were looking to be able to provide their own governance, et cetera, and others were looking not to handle that. And so different areas and different organizations in different counties are really at different parts of the spectrum on the HIE curve. So it's really interesting.
Paul brings up a great point, and I think this is important. 2 years ago, as you mentioned, Paul, you and I sat on this stage and talked about what we were doing around HIE in our communities. I don't know how many of you were here for that and remember that, but it was a much different story 2 years ago. I am just shocked at how quickly HIE has expanded across the state, how the perception of what HIE is and how HIE is going to help the communities has expanded in the last 2 years. It is absolutely unbelievable to me, where we are today compared to where we were 2 years ago. It's just unbelievable.
Great. So, what I'd like to do before we take Q&A is talk about the future, and you've really pointed to it, Rich, thank you. But maybe Dr. Mate, we'll start with you. What do you see as the greatest need in terms of expanding health information exchange further, in terms of financing? Is it resources, other resources, participation, et cetera? What are your thoughts?
I think as a physician, if I look at the future, what would be the ideal scenario we would all like to see? And that would be to be able to see the patient in the right place, the right time, for the right reason. And I think the HIE would, once we get to that situation, I think we've reached where we want to be. I think we are very, very inefficient, and we need to find better ways to take care of a lot of our frail patients. I'm a palliative care physician, so I take care of a lot of very frail patients, and it's a challenge. We always end up seeing the patients in the wrong place, the wrong time, for the wrong reasons. And it's actually bad medicine. It's costing us too much, and so we need to improve it.
I do a number of presentations. I just did one for the National eHealth Collaborative, and one of the things that I point out every time I do one of these is that we are in our infancy. If you think about where HIE is, even today, we're just learning to crawl. I don't think we fully grasp what the capabilities, what the future holds for us in terms of services, added value to physicians, to patients, the expansion of patient access, portals, PHR, the ability to expand the services to do real population management, public health expansion, those kinds of things. I don't think we've even begun to scratch the surface on what we're capable of doing going forward. So I'm really enthusiastic and really excited about the future. I think what we're going to see is we're going to see services and capabilities deployed that just blow everybody's mind. And you know, I'm a big advocate for seeing innovation and recognizing where we can go and what we can do with what we have, but I don't think we've even scratched the surface.
I've often said that HIE is not a destination, it's an ongoing evolutionary process. And so part of this whole long road into the HIE really requires a lot of different things that need to occur. And so one of the things that you know, when you talk about what's happening in the future, the future really is now. And so what we're seeing through the California Association of HIEs, a lot of collaboration with the HIEs working together. Since California really does not have a centralized HIE, we're more of a web of HIEs. What we're seeing at that level is connectivity between the various HIEs, so that really when the patient starts to travel around California, and they're from Southern California and they're going up to Tahoe to be able to ski, or if they're going up to Napa to drink some wine, they're really having that patient record flow with them. And so to the California Association of HIEs, you know, Acreo's already started to connect with a lot of other HIEs within the state. And so that type of collaboration should continue and will be continuing in the future. With regard to the patient, I think there's a lot of hesitation with the patient and PHR. There's always the issue with regard to, well, which PHR is the dominant one. You've got a hospital with a PHR system over here, you've got an HIE with a PHR over here, then the physician has their own PHR. And so there's the issue with regard to PHRs and how that's all going to settle out. So it is an evolutionary process, and it is a revolutionary process, because if you look back where we were 2 years ago, we were at a completely different place. You know, now through the help of a lot of the organizations getting together, which is true collaboration is what we're doing, we've been able to make significant strides as a community.
Last question I have to ask. So in terms of that evolutionary process, then how do you define success? What does it look like for your organization?
Success, I look at, you know, as Dr. Mahdi mentioned, success of a HIE in particular is really how many people you get participating on it. You know, and what's important is to provide something that the community is looking for. And so not a service and hope that they will come. You really design the services to fill the need in the community, and that's what continues need to be done. What's interesting, though, is that you know, you measure success by participation, but it's not enough really to be able to get lives on there. You really need to have organizations using the system, because you can sign up, you can have, you know, a billion lives, but if there aren't any transactions going across, then the system really doesn't work. And so you're not really changing the way healthcare is being practiced, and that's what HIE needs to do, is to help facilitate the change of how healthcare is being practiced. You know, you want to make sure that all the information is there at the right time, at the right place, but you also have to condition the physicians to do that. And I think that what's happened, you've had a lot of consolidation with regard to the data. So you're gathering data from different endpoints and gathering it, but what you need to also do is to set it up so that you're not impeding workflow. So that when the physician is signing on and, you know, treating a patient and he goes into his EMR system, he doesn't have to log out of his existing EMR system. The system automatically is populating, being populated from the HIE into his. So he doesn't really see it. It's seamless. And so that's where the future really needs to go, so that HIEs are not at the forefront of providing all this information. They're really in the background seamlessly running.
You know, I think we often forget, and I'm the biggest victim of this, or the biggest perpetrator of this, and that is that it's about the patient. I mean, at the end, I'm sorry if I'm stealing your thunder, Dr. Mahdi, but it's about the patient, it's about outcomes. Once we can leverage the HIE to really demonstrate positive outcomes in our communities, I think we'll have demonstrated success. We're not there yet. I'll be honest with you, we're not there yet. We're seeing improvements in efficiency, we're seeing the availability of data, but we're not necessarily seeing those measurable outcome improvements, and that's what we need to demonstrate. At the end of the day, we're not successful until we can demonstrate improvement in outcomes.
Last word?
Last word? Well, I always like to have the last word. I never get it at home, so. I hope my wife's not listening to this. I think for our community, I think what I find really great about the HIE is we've actually broken down a lot of the silos that we've all built in the last 20 years. We built so many silos in the Riverside area that you go from one silo to another, and there's barriers between getting information from one place to another. And ultimately, who suffers is the patient. Ultimately, patient's care is compromised when they go from one silo to another. And I think the HIE has broken that. We're actually sitting at tables talking with competitors about ways we can improve healthcare in our community. And I think the HIE indirectly has really played a big role in that.
Well, let's open it up and have some questions.
Years ago when you were on there, wow, you were. I was pleased to hear that you mentioned behavioral health. How is that being involved now in the Inland Empire?
So we've actually made some really good progress in terms of our integration of behavioral health. Obviously, we still have consent issues that we have to deal with. Obviously, in an opt-out environment, certain behavioral health data requires an affirmative opt-in. So building a layered consent model is really what we've been focused on. We've gotten to a certain point. I think I mentioned this probably 2 years ago. There's a 3-phase approach that we've taken to the integration of behavioral health and other types of sensitive clinical information. The first was really to provide access to the behavioral health providers, provide access to the clinical data, to the medical data, by giving them access to the portal. And that first phase is really the sort of the most basic element. We've done that. The second phase was to integrate behavioral health data that was not protected by CFR 42. So for example, lab results, medications, et cetera, that weren't necessarily tied to a diagnosis, a behavioral health diagnosis. We've completed that. So that data is now available. The third phase is really to provide the diagnoses within the HIE, to provide diagnoses, to provide visit notes, those elements that are protected under CFR 42, and therefore that requires our consent model. We're in the midst of working on that now. And so interestingly, you saw San Joaquin Behavioral Health in the video. They're one of our participants, and we're engaged, or will be engaged shortly, in a demonstration project to really integrate that last phase of behavioral health integration. And I can't tell you how important it is. I will tell you that there are some obstacles, though, that obviously that we've run into, and one is that behavioral health facilities don't tend to have electronic medical records. I don't think I'm telling anybody anything they don't already know, but HIE requires electronic data. And I may be good, but I can't translate a paper record into an electronic record on a global basis. And so we really are still working on it. We're still engaged. We're still involved. There's a lot going on in that area.
Are doing a lot of good work in the HIE direction. It appears at a higher level, you've got the regulatory environment, you've got the technology, then you've got the processes. And they're all going to be different in different areas. The question I have is, with all the initiatives that you have in the state of California, and everybody's, I'm sure, doing a wonderful job, is there a mechanism where you're actually sharing your experiences, the pitfalls, the nuances with the other groups? And if there is such a middle piece, could you describe to me if that piece exists today so that every one of the HIEs can learn from others?
That's a very good question. Currently, the California Association of HIEs really works together as a collaborative effort to be able to get all the HIEs to the table, to be able to not only share experiences with those that have done it successfully, but those that are also really starting down that path. And so if you're interested in joining that organization, I know you can reach out. I know Dave mentioned someplace in the audience. He spearheads that effort. with us. There's I would say 22 organizations that were represented at our meeting yesterday. And so we really get together to really guide best practices, who's doing what, how can we work collaboratively together. And so I know the gentleman asked a question with regard to behavioral health. OCPRIO is working with Santa Cruz, San Diego, and Redwood MedNet really to start identifying with behavioral health and really what is something that all of us can do in this pilot that we're working together with the four of us, but also then take that and to expand that statewide to be able to use the best practices that we've learned and the lessons learned to be able to implement behavioral health and then look at that and provide those services into the HIE. So to answer your question, it's really the California Association of HIEs, HIE really is the form that's used. We meet regularly. You know, there's a website so you can go on the internet really to look at to see when the next meetings are held. And so the meetings are done conference calls.
Thanks, Paul. And Pam has reminded us that we'll hear more about that this afternoon.
Yes, I'm writing stock notes in class. Writing notes and holding up signs. We're going to talk more about resources that are available to learn from the microphone. You guys can hear me, right? I have a big mouth. I was a cheerleader. So we're going to hear more about the resources that are available this afternoon, public resources to help everyone learn from best practices, but also, ooh, don't try that because we did it and it didn't work. So it'll save you some money and time, hopefully. I'm done.
Thanks, Pam. And we still have time for a couple more questions. Okay.
Mike.
All right. We are back in action. Hi, my name is Gora Dada. Thank you, panel, for the excellent discussion and taking a lead from Scott's question about the future and Dr. Mahdi talking about not having enough patients on the exchange. Looking at the future patients, what I call the iPad generation, where people text to each other then talk, what are you thinking of in terms of mobile computing and getting the patients of the future connected to the HIE?
Oh, okay. You're just looking at me. We began a project. This is an interesting project with Verizon on a secure texting solution, and we're still early on in that process. But you know, I was shocked at the uptake, interest around secure texting. You know, we can do secure messaging, right? Secure email, and there's direct, and there's messaging within, you know, the HIE environment. But secure texting is one of those areas I think is just, it's very interesting. I don't know how it's going to work. And obviously my biggest concern is, you know, I don't look good in orange. I think you guys have heard me say that before. So I'm obviously very careful as we go forward. But I'm excited about this pilot, and we'll see where it goes, and I'd be happy to give feedback at a later date on how that's progressing.
With regard to, you know, the younger generation, you know, they're much easier and more willing to share their data. So I don't really think it's an issue of getting that data or sharing that data with them. And it was also on the small electronic devices. But what I think, though, is going to be a key with them is because they're not necessarily more accepting with certain things. You know, they're more apt to, with regard to safeguards in their data and things like that. I think the older generation would limit seeing their data, you know, more than the younger generation.
I will tell you, just as a side note, I read an article recently. Twitter did a medical study, and what they did is they took all the Twitter feeds from a community in the Northeast for a period of about 60 days, and they were able to actually leverage that data to predict health issues, public health issues in those communities, based on the Twitter data, right? I don't feel good today. I'm not going to work. You know, and it was interesting. The article is interesting because they were able to leverage social media data against public health and health outcomes. So very interesting article.
Last question right here in front, Doctor.
My name is Craig Lindquist. I'm from the Department of Health in Marin County. One of the things that Rich commented on in talking about one of the things that we need our own. Rich, can you comment on what you foresee as the future of HIEs and how it interfaces with public health departments and community health and health population data?
That's a fantastic question. You know, right now we're working with the public health agencies in the communities that we serve, the smaller communities that we serve right now. We haven't spreaded that out to the other communities yet, but you know, we have public health officers that sit on our governance. Because I believe, and they believe, and I think our whole governance agrees and our board that public health is probably going to be the benefactor of most of this work. You know, while the patient sits at the center, I think public health has a vested interest in that patient's well-being, and therefore public health is going to benefit the most. So, you know, in terms of doing things, you know, meaningful use-related public health, immunizations, ELR, syndromic surveillance, et cetera, I think those things are sort of just the surface of where we're going with public health. As a matter of fact, in our policies, and of course it's supported under HIPAA, but within our policies, we have an exclusion for public health as it relates to being able to do community-based reporting. So being able to actually geocode particular regions and then be able to produce measures around those particular geocoded regions, which of course is exclusively a public health need for the most part, and the ability to expand needed services into those communities that have the greatest need. So I am a big believer in public health. I'm so happy that Scott is now with the Department of Public Health because I think he's a great mind at the state level, and very excited about what's happening with the public health integration.
And that's a great segue to encourage you to come back swiftly from your 15-minute break. We're going to take a brief break. Please be back at 10:30. And you are literally hearing the topics build upon each other. So I'll see you in 15 minutes at 10:30.
Thank you, Rich. Appreciate it.